I'm Jennifer Boyd. I'm a physician assistant, and I work for New River Health Association in a number of different sites in Fayette and Nicholas counties. So anyway, thank you guys. This patient is a 54-year-old Caucasian male who has Unicare for his health insurance, and he was referred to me by one of my colleagues. They've been referring people after I did a little bit of promotion, and a couple of people I work with I'd like to do a shout out to, because they really are just in the habit of screening for Hep C, which is great. I think people are putting it in the forefront of their mind more often. When I talked to him, it was a telehealth visit because he had just had an in-person visit, and he lives quite a ways from the location where I work. He told me that he had never known before that he had Hep C. He just found this diagnosis in our organization this year. He's had elevated liver functions in the past, and he said that 3 years ago he had an ultrasound that showed a fatty liver. I don't think he was screened at that time for Hep C. He's alcoholic or heavy drinker, at least a 12-pack a day. I think probably more. He says he can go without it. But he has gone to AA in the past. Oh, that's right. I forgot he told me he gives blood regularly. I don't know. I would assume they screen for Hep C, but I don't know about that. He did admit to intranasal cocaine use about 7 years ago. I don't think that was for any extended period. I can't remember if it was more than once, but anyway, he denied any other drug use. This was interesting to me. He had worked in sewage treatment since 1993, and he did get vaccinated he thought he got vaccinated for hepatitis A while he was working there. I'll have to look at his labs to see. I can't remember if that was confirmed in his labs. When we get to that, I'll know. But I was just interested, could that be a risk factor? It seems like if you had a lot of direct exposure, possibly. At any rate, no other risk factors. So the interesting thing about this, or one interesting thing about this patient, is that I think I first met him in late March by telehealth, and recommended that he try to stop drinking, which he said he would do because to be able to get the treatment through his insurance. And then I didn't hear from him a long time, and that was because he had a really fairly severe accident. He fell while he was intoxicated. He hit a glass table and had numerous rib fractures, 8. I can't remember what else he fractured, but he was hospitalized in Roanoke, Virginia for that. I don't quite remember the details of how he ended up in Roanoke, but at any rate, eventually when he was discharged, I had a follow-up appointment with him. He was still really eager for treatment. He was healing slowly. He had not had anything to drink since that accident. He was really committed to his sobriety because that accident scared him. It was very severe. Now, let me just say that I also, and I don't think this is in this case, I also had another call with him about 2 or 3 weeks ago, and he continues to have a lot of pain from his injuries, and he was weaned from hydrocodone to gabapentin for his pain, along with ibuprofen, and he's back to drinking. He's drinking about a 6-pack a day, he says, because of the pain. I think it's also because of his alcoholism, but it helps with the pain. And so that's unfortunate. He was following up with Roanoke the week I spoke to him. I also referred him back to his PCP to talk about, other treatment options, because he did say that at the time he did not have this baclofen, and he said that really helped. So I thought that would be a better alternative to either alcohol or hydrocodone for him. So these are his medications, and I think significant are the famotidine. He really shouldn't be on that Versol. But anyway, the famotidine, possibly the gabapentin, and I thought maybe he was on a statin, but I guess he's not. So then you can see his other medications there. Okay, if you can scroll down. Oh, here we go. Yeah, quite a few more. What was other famotidine? No, omeprazole. That was the one I was concerned about. The oxycodone. By the time I spoke to him, he is no longer on that, and he is on simvastatin. So he thought he was vaccinated against hepatitis A, but he didn't have any antibodies. So we are revaccinating him. He does have immunity to hepatitis B, and there's a surface antibody titer. He has a normal BMI. Let's see, normal CBC. That creatinine was normal. PTINR were okay. I think his liver enzymes, yes, his liver enzymes were elevated. As you can see, alk phos was normal. His APRI was 0.82. He's a child Turco-Q class A. His MELD score was 7. Iron studies, his ferritin was elevated. Vitamin D, I've started him on replacement. He's HIV negative, genotype 1A, with a viral load of 229,000. And his serum fibrosis marker was his F score was an F3. I am waiting on a repeat. His ultrasound from 3 years ago did not show any fibrosis. I'm waiting on elastography. My thoughts were that I could treat with epclusa, and I think I would need to adjust the dosing to avoid his PPI or Mavorite and stop his statin during treatment. Does that sound right? And my another question is if his elastography is consistent with that fibrosis score or worse. Would he need regular ultrasound surveillance? And I didn't get an AF, or I ordered it, but the AFP wasn't done. And I think I ordered a repeat because he was coming in for his Hep C or Hep A vaccine anyway. My biggest concern with this guy is he's back to drinking, and I'm not sure that I could get his medication approved if he's still drinking. Those are my questions, and that's his story. He's a nice guy. I feel kind of bad for him because I think his alcoholism is worse than he's willing to admit.
Thank you so much for that, Jennifer. Does anybody have any questions for this case before you go to recommendations? And I can always pull the case back up if anybody needs to see any of those. All right, since we have that silence, go ahead and anybody recommendations, please.
Sure. Jennifer, I can understand why you're getting referrals. You've garnered expertise. Congratulations. I mean, everything that you're bringing up as a concern, it's exactly what I would identify as well. So good stuff. This is a guy you can really help. To start with, I don't think that you need him to have a sobriety period anymore. Rachel, you can help me on that one, but Medicaid's not requiring that anymore, if I'm not mistaken.
Awesome.
Yeah, so you can really help him. The points I found most fascinating is that he's donated blood routinely. I don't know what that's about. That's I hope that's not true. But whatever, he shouldn't be able to donate blood. His Hep A vaccination status could save his life. Remember, Hep A can be just an annoyance for a month, but concomitant Hep C and chronic liver disease plus Hep A can kill you. And he's a sewage worker, so he's putting himself in contact with the bodily fluid that has the highest concentration of hepatitis A. And so, yeah. Now, the medicines I see, and Rachel's on here, and so I'm gonna let her comment on that, but I saw the Pepcid, omeprazole, and Zocor all on the list. And the parts that you identified as solutions to avoid those are, I 100% agree with. he probably doesn't need to be on both the Pepcid and omeprazole, and if he is, just getting him on the right dose of omeprazole, and then going with Harvoni or Epclusa, or getting rid of Zocor transiently, and going with Mavorite, whatever he seems to tolerate. Now, the question you had about his APRI and FibroSure and elastography and all that. So regardless of what the elastography will say, you've got two biomarkers that agree. So the APRI score is 0.83, so greater than 0.7, implying that he probably has some scar tissue. And your FibroSure says he's an F3. So, you know, one of the things is when we're trying to triangulate the truth with regard to fibrosis, we don't know which one is the best. And so you kind of have two of those that say, at least for a while, I would consider doing Q6 month ultrasounds for him. After you treat him, if his APRI is normal, and if you repeated a FibroSure afterwards and it was normal, and then his elastography was also normal, you'd probably be like, okay, I have a preponderance of evidence that says I really don't have a lot of scar tissue, which would be oncogenic. But at least with the data you have right now, he would qualify as F3 or greater with consistent data points. So I would plan to do HCC screening. I don't think you have to do alpha fetoprotein on him.
Thank you.
Yeah, Rachel, can you double check me on the sobriety period question mark in Medicaid and then the drug interaction?
Sure can. You guys, can you hear me okay?
Yep.
I'm worried that my headphones are dying because I'm getting a weird crackle. So somebody wave if I stop. But you guys got it. You nailed it. Everything with the things that I was picking up from drug interactions. So yeah, you can stop the statin if you want to do Mavorite for that short period of time, or that issue with the Epclusa that's going to be with the PPIs and H2RAs. You know, whatever you decide, you know, pick one, and you could manage it. With administration, the doses look okay. You just have to worry about the administration, you know, same time with the H2RAs or 12 hours apart. They, you know, depending on if they're really, you know, taking it once a day or twice a day. And then with the omeprazole, let me see, double check. This says 40, so that dose is too high with the Epclusa. So it would have to be decreased to 20 max if you would have to go with the Epclusa. So the only thing really, you know, from a drug interaction standpoint, you already know what to do. It's just to decide with him which one he's willing to stop, and which, you know, does he eat regularly? Could he do the Mavorite, taking that with meals, or, you know, does he want to do one pill for a longer time for that 12 weeks? So you've got some options there. There's nothing contraindicating therapy. And from the way that they updated to change now to the sobriety question, when they updated that patient provider consent form, there is no specific instructions that say the patient has to be drug and alcohol free for 3 months prior to treatment. That's what it used to say. What it says now, and what we've that we kind of follow, is that you have to educate the patient on the importance of not using drugs and alcohol. So that's really what the patient and you are attesting to, is that they've been educated that the best thing for them is to not use drugs and alcohol while on treatment and after. So there is no specific, they must stop drinking. So that shouldn't prohibit you from submitting this authorization and this consent form, because you've educated the patient and told him he needs to stop drinking, and that's something that he can work towards, but he can still be treated even if he is still currently drinking.
Okay, that's great news, actually. So thanks a lot. Okay, thank you both. That was helpful.
Sure.
No more questions.
Awesome. Thank you so much. Thank you, Jennifer. And thank you to both Rachel and John for that. All right. Dr. Bailey, are you ready for your case now?
I am ready.
Perfect. Just give me one moment, please. Can you see that okay?
Okay.
Perfect. Go.
All right. So this is a 40-year-old male who presented to establish care with me. It's probably been about 3 or 4 months ago at this point. He had initially seen one of our nurse practitioners, and she said, "Whoa, you are probably complicated enough that you deserve to have a physician." And so he has a pretty, not a long medical history, but a pretty complicated medical history. He had a run-in with endocarditis that was a complication of IV drug use back in 2020. He was in the hospital for a really long time, ended up with, he had valve replacement. Well, I think it was just a ring repair actually, but the first time they used the wrong size ring. So then they had to go in and change that. But then as a complication of the endocarditis, he got a giant abscess in his right leg that had to be drained, and he came real close to losing that leg, but thankfully that healed okay. He is left with some pulmonary hypertension because I think he had some big cavitary abscesses in his lungs. And, you know, he nearly died in several different ways during that. He also came out of it with stage 4 chronic kidney disease. So he was on dialysis for a while when he was hospitalized with that, but they managed to get him off dialysis when he came home. So his last relapse was honestly probably about 16 to 18 months ago at this point. It was, I think, right after he came out of the hospital. You know, he had came out sober and then had a relapse and said, whoa, I've got to make some changes in my life. Got in with a Suboxone program, and he moved from North Carolina to get away from people that he was kind of hanging out with, that were, he was used to using drugs with, and came to live with his uncle in Welch. He's from here originally, but he had been living in North Carolina for a long time. He's been really consistent with going to his Suboxone program. And other than this one really big, you know, thing that happened to him, he is pretty simple. He just has the history of substance use disorder. He has chronic kidney disease, which was a sequela of this, the pulmonary hypertension, and the history of open heart surgery. And then he's got some insomnia, and his teeth are bad. So that's something that we're kind of working on. But right now, all he's taking medication wise is Suboxone and hydroxyzine. If you'll scroll down a little bit more. He came to us not immune to hepatitis A or B, and we have started him on those vaccine series. He should be close to done, if not done at this point. He's a relatively normal weight fellow. Lab work is notable. His platelets are kind of on the low end of normal, but not terrible. But his creatinine is quite high in stage 4 kidney disease. I don't see, his liver enzymes are kind of modestly elevated. Nothing really else that's particularly noteworthy on his labs. You want to keep scrolling? His APRI was below 1, so that's good. His MELT score is high, of course, but that's being driven by his chronic kidney disease, I think. His ferritin was a little bit high, which I think is probably inflammation, maybe related to all these dental infections that he's having. I mean, when I saw him most recently, like his face was really swollen up, and I think that's when we got those labs. So I think that's probably an acute phase reactant. But honestly, if he was infected and his platelets were just 185, that makes me wonder, maybe they're even lower sometimes. But genotype is 1A. He's got a relatively low viral load, 322,000. And then his fibrosis score is F1, F2. So his liver is not doing too bad. So my thought with him is that he's actually probably pretty straightforward. Mavorite for 8 weeks. I don't see any dosage adjustments needed for his chronic kidney disease. So I'm guessing that's cleared through the liver, which seems appropriate since it's targeting a virus that lives in the liver. And his MEL's a little high, but again, I think that's more related to his chronic kidney disease driving up his risk of death there. So I don't think he needs referral to a transplant center at this point. And I really anticipate this guy doing pretty good in the long run if he is able to kind of stay sober and take good care of his kidneys and things like that. So.
Great job. Thank you so much, Dr. Bailey, and thank you for this case.
No problem.
Does anybody have any clarifying questions? All right. Go ahead and unmute when you guys are ready for the recommendations.
Hey, Joanna, it's John. Good to see you again.
Yeah, it's good to see you.
And well, I guess you can't see me. See, I'm hiding behind the black screen.
It's good to hear you.
Yeah. Crazy story. Yeah. You know, the first thing that came to mind in this guy is, first of all, I agree with you 100%. I guess I get to the Hep C stuff, and then yeah, you are 100% correct. The CKD, when that used to be a question mark when these DAAs first came out, we really didn't know what to do with them from that perspective. And you know, that was kind of the initial niche for Zepatier. It sort of had some data but now they all do. Now there's no limits on any of them. So we're basically able to just use any of the drugs we want to use. And he's got Medicaid, so you have Clusar or Mavorite. So yeah, I agree with you. Shorter is better. I'd give him 8 weeks of Mavorite. Doesn't look like he's going to need long-term HCC screening, and I would just keep an eye on that ferritin. It is kind of creepy. I don't know what to do with it. You know, he's African American, so I don't know what the rate of hemochromatosis is there. I don't think it's as high as in Caucasians, but anyway, just make sure it's a secondary process and it drops over time. But then two things. I wish inpatient centers, he probably was here. I don't know where he was when he has endocarditis.
He was down in North Carolina somewhere.
North Carolina. Well, even if he were here, we wouldn't have treated him, and it stinks. You know, you have this time period of a captive audience. He probably spent a long enough duration in the hospital. We could have treated this hepatitis C and cured it.
For sure.
Yeah, that's just not on inpatient formularies, sadly. But I bet $20,000 for a medical course would have been a drop in the bucket relative to what his entire hospital bill was. The only thing I wanted to point out is, man, you know, even more than his Hep C, his teeth scare me because of that artificial valve. You know,
yes.
the biggest threat to this guy's health is, you know, endocarditis begets endocarditis, and it's primarily from teeth. So scares.
I agree. So I did not hesitate to give him an antibiotic that day. I saw him at our Gary office going to the dental clinic the following Thursday. So it is being addressed.
Yeah, that was my ID hat freaking out there, but nope, I agree 100%. I didn't see any contraindications, nothing tricky, and beautiful thought process, and I concur with your plan.
Awesome.
Thank you so much, Dr. Gilfus. Are there any other comments or suggestions, or do you have any other questions, Dr. Bailey?
I have another semi-unrelated question. I think this is my Echo MO. So, we've talked a lot about fibrosis scans in this group, and I'm in a really good position right now in that we're getting ready to get a new building. I'm getting a new office, and so we're going to add ultrasound to our office for that. And so I'm really looking to get an ultrasound machine that has the capabilities to do fibrosis scan. And so I didn't know if anybody here had any experience with a brand of machine that I could maybe look into. I can reach out to Dr. I think Dr. Tierney has one, and I was planning on emailing her, but I didn't know if anybody else here knew of anything.
Joanna, I don't know which brand we have. I think we actually have changed that throughout the tenure of us having fibrosis machines. I think every major manufacturer has that modality and ability to do it nowadays. But
okay, great.
Specifically ask them, be like, hey, this is something we see a lot of liver patients. We want the ability to do that and make sure that's part of the capacity of the ultrasound machine. My understanding, it's mostly just software and probe issue, and most of the machines can. But yeah, sorry, I'm not helpful. I think ours was a Philips machine most recently, but I don't want to coach on that one.
Okay, cool. And I don't have a problem cold calling radiology. I'll do it.
100%.
Yeah, I think ours here at WVU, because we have the conversion that we send to RDT when we send those in, so they know which scan we used. We have the brand FibroScan. That's the newer one that we have.
Mm-hmm.
And then I think you're right, Dr. Gilfus. I think it's Philips. I'm looking at the sheet here and it says LogiQ E9. So LOGIQ E9 elastography. I don't know if that's the brand name or the software, but my understanding that one was the first one that we had, and it like attached to the ultrasound machine we already had. I could be very wrong on that, but that's the brand names that we have, at least on the papers that I have for reference.
Okay, gotcha. Yeah, I got those written down. Thank you.
Excellent. And I see that you saw Tammy chat that. That's great.
Mhm.
Thank you so much, Tammy.
Dr. Bailey, I'll email you Tammy's email so you guys can connect via email if you guys don't have each other's contact.
Okay, yeah, that'd be great.
Perfect. Thank you so much, Mitra. All right, if there aren't any other suggestions or questions, we can move on. Our third presenter doesn't seem to have made it today, but that is fine. We'll just go ahead and go into Dr. Gilfus's didactic. Would you like me to share your screen, or do you want me to give you the capability to go through your slides, Dr. Gilfus?
Yeah, if you don't mind sharing it with me, that is a little easier.
For me to do it or for you? Sorry.
Oh yeah, I was not clear. I should definitely do it myself since I'm communication impaired without a doubt today. So yeah, if you give me the ability, the green button says I can share. So
You should be good. You
I
should
should
be good.
All right. Is that showing up?
Yes,
See
that's
it?
perfect.
All right.
Perfect.
You know, I never know how much interest there is in HCV, HIV co-infection, because I don't know how many people are taking care of patients with HIV at this present time. But an unfortunate fact is that you will. So, you know, we have been incredibly blessed in West Virginia to not have our opioid epidemic commingle with our HIV epidemic much. And that's significantly changed in the past 20 years since I've been doing HIV care, and a larger and larger percentage of our patients who have HIV are having their risk factor be injection drug use. And as such, co-infection is becoming more and more common. And so just having a sense of how to approach these patients, is there anything different? Do we have to even, you know, or is it just like Joanna's patient with the CKD? Does it even matter? And that's what I'm going to try to talk about a little bit. And by the way, I could summarize this as saying everything you imagine that these two viruses would do to each other, that's what they do. There's nothing illogical or odd about their relationship. If you're a pessimistic realist, which is what I like to pretend I am, in other words, a pessimist, the interaction between these two viruses is what you'd think. So it's unlike hepatitis B, where hepatitis B has a really unusual relationship with hep C, which we talk about a lot. This one is more what you'd expect, for the worse. You know, I had this case up before. I kind of love this case. The reason I had this brought up is because, you know, we do labs like every 6 months on our HIV positive patients. And this guy doesn't use drugs. And one of his times we were doing his liver enzymes every 6 months, just as part of our routine testing for to make sure that people are tolerating antiretrovirals. And lo and behold, his liver enzymes were sky high. And I was like, what? Uh-oh. Now, then I called him back to do HCV testing, along with a bunch of other testing, and it was reactive. So one of the things, this was 2013, it kind of taught me that I should be doing more HCV testing on my MSM population, because this acquisition was from it was like an STI. So as you're doing STI screenings in the MSM population, consider hepatitis C. And the other reason I like this guy's case is because initially cleared, you know, had I only checked, the exclamation point says there's an abnormality. So if you look down here, I don't have it pulled up, but it was undetectable. So he actually initially looked like he became undetectable. It's one of the reasons, his case was one of the reasons that I always make sure to not just check a viral load once and tell someone they're fine. Because had I only looked once after he cleared, I would have falsely told him, you know, that, hey, you're good. But then when we kept following him, it sort of came back. Whether he got reinfected from ongoing sexual exposure or it never really fully cleared, I don't know. But you can see his liver enzymes were telltale. So anyway, kind of a cool case. But the themes are co-infection is common and becoming more common, whatever the correct English is there. There's more of it. There's more of it happening. And there's increased transmission of HCV in the presence of HIV co-infection, and that can be either as an STI, so sexually, or it can even be mother-child transmission. And as I've mentioned, the relationship between these two viruses sort of does what you'd think it would do. And there's increased rates of fibrosis, and we'll talk more about that. And I guess the bit of good news that we'll end on is that you can treat these patients and their response rates are beautiful. They are on par with our expectations for mono-infected people. But there's a bunch of drug interactions. So you need a good pharmacist like Rachel and our allied health specialty pharmacy to help us to make sure we don't, that's really the major issue is drug interactions. So I said it's common. It's just because the route of transmission is shared. So we all know injection drug use is the major risk for HCV infection, and unfortunately is also now becoming a increasing risk for HIV infection. And you can see the overall statistics there. Maybe 25 to 30% of people who are HIV infected also have HCV. I will say traditionally that has not been true in Northern West Virginia. We've been more around 10%, but as our risk factor has increased from less sexual to more injection drug use for HIV, we're seeing more and more HCV co-infection. And that's kind of what the second statement says. So in places where the risk factor is injection drug use, which really, the southern part of our state, one of the predominant ways of HIV acquisition is IVDU. The rate of HCV co-infection is much higher. And I thought this was an interesting factoid. So the sequence of infection often is different based upon the risk factors. And this is just talking about transmission kinetics as well as just what's more common. So if you're an injection drug user, you usually acquire HCV before HIV. And vice versa, if your risk factor is sexual, you typically get HIV first and then HCV. And that's because the HIV augments the transmissibility of HCV sexually. Here's some epidemiology from West Virginia. Let's kind of work through this slowly. So it says that the HCV HIV co-infection is largely driven by the opioid epidemic. And again, not 100%. We absolutely do see some sexual transmission. But those patients that we see who have HIV related to IVDU, you can see it's 60 to 80% actually have HCV co-infection. So these graphs were from the last time the state published data on co-infected patients, and they both looked at hepatitis B and hepatitis C co-infection in HIV positive patients. And if we sort of look through, it says co-infection by transmission category. You can see for hepatitis B, the primary risk factor is sexual transmission, which is what we know that. We know that hepatitis B is much more sexually transmitted than hepatitis C, but there's still a substantial amount of hepatitis C that is sexually transmitted in the setting of HIV. And then injection drug use represents the preponderance of hepatitis C patients co-infected with HIV. The other thing I found interesting here was the age distribution. So traditionally, when we talk about what do we consider the high risk patients for hepatitis C? We think about the baby boomers, okay? But if you talk about HIV positive patients with hepatitis C, it's almost entirely the drug using population. So it's the age group that does represent risk factors being IVDU. Yeah, and so what's the issue with sex and HCV and HIV co-infection? Well, it happens more commonly. And the rationale behind that may be that there's more HIV, there's a permissive environment for HCV transmission, and there's actually evidence of higher levels of HCV in sexual fluids. Also, not only as the insertive partner, but also receptive partner. There is more sexual transmission in MSM, HIV uninfected, than heterosexual sexual transmission, but not nearly as high as with HIV infected. And do know as a factoid that if you have a coexisting STI, it can increase or augment the transmission of HCV in the setting of sex as well. So if you have ulcerative STIs, especially HSV being such a common diagnosis, syphilis, LGV, etc., that it can increase the likelihood of transmission of HCV during any one sexual encounter. So again, this is kind of unique to HIV positive relative to our heterosexual in HIV infected. Now, perinatal transmission, again, I think Dr. Feinberg is going to give a whole didactic on this. She was going to give it, but then was traveling on the interstate and lost service, I think, in June at some point. And I'm excited about her updates on this. Do know that our traditional quotations of rates of mother-to-child transmission are probably low across the board. They're probably low. But one of the truisms that has held true is that you have nearly double the transmission rate. Whatever that true transmission rate is, it's probably doubled in the setting of HIV co-infection. And yet again, the thought process is the same thing. Having HIV sets up this permissive milieu of higher viral loads, being in more fluids, more secretions, and then transmission from mother to child at the time of delivery. These viruses don't really play with each other nearly as complexly as hepatitis B and hepatitis C. Just know that they both have set points. They both kind of do their thing. And usually we know HCV viral loads. We review those all the time in this echo, and they're anywhere from tens of thousands to hundreds of thousands to millions. And for HIV, it tends to be a logarithm lower. So you tend to see thousands to 50,000 to maybe 100,000. So in general, about a log or 2 logs less is your average viral set point. Big difference for the two viruses is, we always preach that the HCV viral load doesn't matter a ton with regard to rates of progression to chronic liver disease. Opposite is true for HIV. If you ask me what's the single most important value to know for your HIV positive patient, it's the viral load. Higher is definitely worse, more transmissible, number one. Number two, higher rate of progression to AIDS. So viral load does matter a lot more for HIV. And the relationship between these two, I'll talk about in a second. HCV levels, if you had somebody who you had their known set point and you suddenly gave them HIV, your HCV levels could increase. Again, functionally probably doesn't matter a lot. And I'll get to the only potential functional consequence of that in a second. And there's some whys there that don't matter, and they don't really know that they're true, but it's just, that's an observation. It probably has something to do with the fact that your relative immune control that you've established with your semi-homeostasis with this chronic virus is perturbed because your immune system is getting knocked out. And that's all that says too. And it's a pro-inflammatory environment. Having HIV and HCV both are pro-inflammatory, and that pro-inflammatory milieu is not good for the human, not good for the liver, not good for anything. And that's why I said this is kind of reasonable. You can imagine that anything that causes a double whammy from a pro-inflammatory standpoint isn't going to do good for the body, not going to do good for the liver, not going to do good for the immune system. So what is the exact effect of HIV on HCV? I feel like we very well described in ECHO the natural history of HCV. We all know that there's a good percentage of people that will clear this virus on their own in the first 6 months. Remember the old textbook saying 10% to 15% are probably wrong. It's probably more like 30 to 40% of people that actually do clear HCV normally. And those that don't, there's about 2/3 will go on to some form of chronic liver disease, but you often talk about 20, 30 years. Well, what happens with HIV is you're less likely to clear it. So you can see only about 10% of people clear the infection. So far fewer than you'd expect for a mono-infected patient. And you have far more rapid progression. So rather than having that 20, 30 years, you can see very, very kind of absurdly fast fibrosis. And I have some, numbers written up there that were from a single study, but I'll tell you, the power of anecdote. So I have followed multiple patients over time who I've watched go from not infected to a known acquisition of HCV to significant fibrosis in 5 to 10 years. And that's, really fast, really fast. In fact, some have been cirrhotic quite rapidly. And so I have huge respect for what this co-infection can do for the rapidity of progression of fibrosis of HCV. Now, mind you, those patients I'm talking about were in the late 2010s prior to DAAs. I would no longer sit and watch and wait anymore. I would treat these people rapidly. But before we had the direct acting antivirals, our therapies were lousy. And I did unfortunately have to watch people, just watch their fibrosis progress. And it was astonishingly rapid relative to mono-infected patients. Okay, so what else? So risk of, bad liver, extrahepatic manifestations. Remember when we talk about extrahepatic manifestations, the mechanism of those is a lot of times immune stimulation and autoimmune phenomenon. So what happens with the co-infected patients, I already mentioned, you have sort of a double whammy from immune stimulation. And autoimmune phenomenon, as a general rule, are much more common when you have immunodeficiency. So remember, one of the most interesting things I ever learned in med school is I went to an immunodeficiency clinic thinking I was going to see infections. And I didn't. What you see in an immunodeficiency clinic is allergies and autoimmune diseases. And I was like, wow, that immune system does a lot more than just fight bugs. It really regulates our internal controls of a lot. And so you think of hepatitis C being such a disease process that promotes via chronic inflammation, the chronic flogging of the immune system promotes the development of autoimmunity. And then you have the dysregulation from HIV, and you can imagine why you see increased extrahepatic manifestations in these patients. Faster rates of HCC progression, and so on and so forth. So as I said, everything that you'd imagine it could do in a negative way, it does. How about the opposite? This one, a little bit less exotic, and probably only matters to those on the call who actually treat HIV. But what does HCV actually do to HIV? Functionally, I have the one that I care about most in bold. So there are a whole bunch of population level studies that say that if you have HCV, in addition to HIV, you're more likely to progress to AIDS. But I never know if that's causality or correlation, because you can imagine that the people who have HCV and HIV co-infection are more likely to be IVDU, less likely to be adherent with therapy, and et cetera. And the ultimate way to progress to AIDS is not taking medications and not being in care. So I'm not sure about the causality for this, but what I do find interesting is that there may be some impact on CD4 cell gains. And so one of the, HIV treatment nowadays is great. You start people on therapy, a 1 pill once a day option, they become undetectable, and voila, life is good. But there is a frustrating subset of patients whose immune system doesn't seem to recover. And we don't have any independent intervention for those patients. So you have people who have a suppressed viral load, but their CD4 cell counts are still really low. And we have observed that if you have a co-infected patient, if these patients by chance have HCV co-infection and you treat them, they tend to have a more rapid CD4 count recovery, which it's kind of nice to have something that you can do from that perspective. Now, we talk about extrahepatic manifestations, perhaps C, all the time. HIV has sort of similar stuff. It can cause problems with bones and kidneys and make you at risk for MIs. And sort of those sort of extra immune side effects of HIV can be attenuated if you treat HCV as well. So that's all that gobbledygook says. Very interesting fact. I forget this one all the time, and I should try not to. When we see people as new intakes for HIV, we screen them for hepatitis C, B, syphilis, blah, 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 toxo, a bunch of stuff. But we do it via serology. And there is at least good studies that say that we shouldn't rely on serology if your CD4 cell count is terrible. So remember, for most people, our screening antibody test is awesome. We don't worry about false negatives. You can see it says it's 99+% sensitive. But if you don't have an immune system that's intact, it's not logical to depend upon that immune system to tell you have an infection. And therefore, you should probably add, in addition to your antibody testing, and those people with CD4 cell count less than 100, you'd want to go straight to RNA testing as well. Or I should say not straight to, but add on RNA testing as well, just to make sure it's not one of these patients that has not been able to form antibodies. You know, the other benefit of adding the hepatitis C RNA is, remember, there's always a window period for your antibody formation. And for hep C, it can be months, whereas your viral load will show up in just weeks after exposure. So what happens when you treat somebody's HIV? Answer is good things. I mean, again, that's sticking with that same concept that everything in HIV and HCV co-infection sort of makes sense. So if you don't treat the HCV for some reason, but just treat the HIV, you kind of slow things down. So as you reconstitute that immune system, there's a decrease in the rate of fibrosis and decrease in the rate of liver cancer, et cetera, et cetera. But now that we have DAAs, we don't want to stop there. We don't want to just give ART. That's ART. I'm sorry, I shouldn't have abbreviated that. That's antiretroviral therapy. So we don't want to just stop at giving HIV treatment. We want to go ahead and give them DAA treatment as well. So are there any issues with having HCV and having increased toxicity from HIV medications? The answer is maybe, but it doesn't matter. It's worth it. So there's no one in the world that would avoid giving somebody HIV medicines purely out of fear that you're going to cause hepatotoxicity in someone with hep C. In a general statement is most people would actually start them on antiretroviral therapy before treating their hep C. Okay, and we don't do that for every chronic illness. Say you had somebody who had HCV and TB. You know, it's a debate which one you're going to treat first there. You're kind of like, yeah, you know, do I treat their latent TB with 9 months of INH or 4 months of rifampin first, or do I treat their hep C first? I'd probably treat their hep C first. But for HIV, most providers go ahead and treat the HIV first. And the rationale is you want to just get their immune system semi-reconstituted. The initial time period when you start antiretrovirals is the time period you're going to have most likely to have side effects to it. And so you want to just make sure you introduce them to one drug first. And then when all is stable and happy from that perspective, usually 2 to 3 months down the road, you can contemplate adding in a DAA. And really, this is kind of the good news slide. So what about treating HCV in the setting of HIV? And the answer is how it works. So comparable SVR rates. Why was everybody so surprised about this? Well, everybody's so surprised because interferon and ribavirin, even with the addition of the protease inhibitors, didn't work. It just didn't work well for our HIV positive patients. Dr. Feinberg and myself always talk about how nasty it was during the interferon era. It was especially nasty for HIV positive patients. Their success rates during treatment were less than 30%. The only people I ever ended up hospitalizing on interferon and ribavirin had HIV co-infection. And they developed cytopenias, hepatotoxicity, all sorts of, you name it, stuff. So I despised using interferon and ribavirin. And it also had an even less likelihood of SVR than even for the 50% we used to quote people. It was more like, as you can read up here, 15 to 30%. Anyway, that's old news. Nowadays, you just treat them, their outcomes are great, and life is happy. The only issue is drug interactions. And so remember, you can go to hcvguidelines.org. They have one of their second tabs down under management of unique and key populations is patients with HIV, HCV co-infection. This is sort of their tenets that are that tell you that, hey, you don't want to stop antiretrovirals while you're treating. And it kind of goes through some of the things you should avoid. I hate reading things like this. It's hard for me to read. I love this table that I captured from hcvguidelines.org. And what it really does is you've got your antiretrovirals over here, and then you've got your HCV therapeutics at the top, and you can mix and match and come up with things that work. For any of you on the call actually who prescribe antiretrovirals and you are crafting a regimen that's friendly, or I should say the ones that are unfriendly are really things that are PIs. So your protease inhibitors or anything that contains a booster. So remember your Norvirs, your cobicistat, those are a challenge. And remember your funny NRTIs, your older school NRTIs, Sestiva and etravirine. But the good news is, what are most people on? So most people are on Biktarvy. Look at this. I got nothing to worry about. Most people are on Tivicay plus dolutegravir. So they're on, something I just have to be careful. So what these yellow things say that is for Epclusa and Harvoni, I've got to kind of watch my renal function. Again, for any of the fellows on the call, Triumec is good and clean if you want to use a regimen without any real concerns with any of the regimens. Overall, Mavorite is clean too for all of our common regimens. Just remember, you don't want to use a protease inhibitor with another protease inhibitor. You're going to run into a bunch of drug interactions. So, but this table is awesome. I go to it all the time rather than trying to memorize. Now, the very last thing I will mention, and this is emphasized a couple times on hcvguidelines.org, is do be mindful of antiviral selection if hepatitis B co-infected. Now, this is like you shooting a dead horse or whatever. I can't remember what the saying is. It's something about a dead horse. It's beating a dead, I can't remember. Anyway, we talk about this all the time. Hepatitis B and hepatitis C co-infection. Add one more variable in with HIV. So remember, you treat Hep B with HIV drugs, but it's only certain HIV drugs work. And so if you do have a patient who has hepatitis C, hepatitis B, and HIV, and you contemplate treating their Hep C, just make sure their HIV regimen is going to control the potential Hep B flare. That's what that says. Remember, not every HIV drug does that. It's really only the drugs lamivudine, emtricitabine, tenofovir, and TAF. So these ones, you want to make sure your patient is on one of those if they're a triple infected patient and you're going to treat their Hep C. By the way, is that even an issue? Aren't almost everybody on NRTI backbones? The answer is no. In 2022, we've got more and more regimens that are NRTI free. So we've got this, injectable agent that has, purely an NRTI. It's got rilpivirine and one of the integrase inhibitors. And we've got a couple other regimens that are basically NRTI free, like Juluca. So this factoid is becoming more and more important to keep in mind. And that was it. Any questions that anybody has that I can clarify?
First, I just wanted to say wonderful job. Thank you so much, Dr. Gilfus. And you just always find some great tables and resources as well. Does anybody have any questions for this topic or comments?
That was a great presentation. Thank you. I put in the chat, I dread the day I had my first HIV positive Hep C patient, but I'm sure it'll happen. So it's nice to have a bolster to fall back on. And according to my PA school roommate, the expression was beating it with a dead horse.
Oh, thank you. Yeah, I couldn't remember. Something with a dead horse. I couldn't. Yeah, I really think we're going to see more and more co-infected patients. It's the public health people have been warning us for years, and it's starting to show up in my clinic more and more. We were 85% sexual risk factor for HIV years ago, and it's turning upside down thanks to the opioid epidemic, which sucks. It's terrible news.
Thank you so much for that comment, Jennifer. Does anybody else have any questions or comments before we do final announcements? Tammy said, thank you so much. As always, really enjoyed your presentation. All right, lastly, just our next session will be July 28th, and that'll just be all cases. So should be interesting. We have, I think, probably 6 cases, so it'll be a pretty packed day. So hope everyone has a great rest of your week. Thank you so much. Bye-bye.
Thanks, everyone.